Good afternoon, everyone, and welcome to today's webinar. I'm Donna Rice, the Chief Operating Officer for Diabetes Sisters. Diabetes Sisters is a member community dedicated to providing support, education, and advocacy for women living with diabetes and those at risk. Our organization offers a variety of educational resources, including monthly virtual peer support groups where women can learn and share their experiences, challenges, and triumphs in managing diabetes. In honor of Vision Month, today's Expert Series webinar is sponsored by Regeneron, and it focuses on diabetes and eye disease. Our expert is Dr. Jessica Randolph. Dr. Randolph is an assistant professor of ophthalmology at Virginia Commonwealth University, where she completed both her ophthalmology residency and medical school. After residency, she completed a vitreal retinal surgery fellowship at the Retina and Vitreous Center of Texas in Houston. Following 2 years of private practice in North Carolina, she returned to practice in Richmond at Virginia Commonwealth University Health System. Dr. Randolph has a passion for medical education and diversity, equity, and inclusion efforts. She is active on several executive boards for ophthalmology professional associations, including the Women in Retina and Diversity, Equity, Inclusion sections of the American Society of Retinal Specialists and the Young Ophthalmologists Editorial Board of the American Association of Ophthalmologists. Dr. Randolph was awarded both the Real World Ophthalmology Inspiring Academic Leader Award and the Woman in Ophthalmology Mentorship Award in 2022. Please help me and welcome Dr. Randolph.
Hi, good afternoon now, everyone. I'm so happy to be here with you all and talk about diabetes. It's something that I see so much in my clinic, and so I am excited to talk to you about diabetes and the eye and a few other eye conditions that you may have questions on. So I am going to go ahead and put my slides up. There we go. All right. So thank you so much for that wonderful introduction and the invitation to be here. This really is a passion of mine to talk to people about eye problems and diabetes and education. And I do a lot of medical education, but I also really like educating the public too. So it's really exciting to be here. So just to start off and talk a little bit about the eye, there's different parts of the eye, and in our world, some of them are as far apart as, like the engine and the windshield of a car. And so just to talk a little bit about how things work. So the front part of the eye is the cornea here. It's the clear, kind of like watch face part of the eye. And all the light goes through the cornea and then through the pupil, which is the hole in the iris or the colored part of the eye. And then the light goes through the lens, which helps focus, just like a lens in a camera, onto the retina, which is the film in the back of the eye. It's kind of like this wallpaper that lines the inside back wall of the eye. And the eye, the white part of the eye is the sclera, which is kind of like the capsule around the eye. And then there's this conjunctiva, which is like the clear skin of the eye. And so, at any part of the eye, you can have eye problems. And in ophthalmology, there are specialists for pretty much every part of the eye. And so I'm a retina specialist, and I work on the back, the film part of the eye. And some of my colleagues work on the cornea in the front of the eye, or the cataract in the middle. So there's a lot of different, I think 8 different subspecialties in the field of ophthalmology. So 8 different things you can do, an additional year of training or 2 on in the eye itself. So small as it may be, it's a vast network of really complicated science, which I find totally cool and amazing. So one common thing, we're going to start with some of the common problems that people may have heard of and just talk a little bit about them. So presbyopia, or blurry vision up close, and cataracts, because they're sort of related in a lot of ways. And so with the blurry vision up close, or presbyopia, this is, you go to a restaurant and the light is dim. And so you want to like hold that menu a little further, and you want a little brighter light. And that's from changes that occur with aging in the lens itself. So the lens is kind of like an onion. And so the more it grows, the thicker it gets. and it's a little bit stiffer. And so when you're young, that lens can shrink and stretch and help focus onto the retina. But once you start getting a little bit older in 40s, 50s, and beyond, then that lens is more stiff. So it can't adjust and bring that focus in up close like it used to. And that's why reading glasses help out, or you find yourself kind of stretching that arm out to see things. And so the treatment for the presbyopia, the trouble with up close vision, is reading glasses. And the cheap kind work fine. I tell patients all the time, just get the dollar store kind and get 5 pairs and put them everywhere. 1 pair in the car and 1 pair in your bag and 1 pair by the bed and 1 pair in the kitchen. So that way you're not always looking for a pair of glasses. Similar to that, the cataracts is that same part of the eye, the lens. Now it's a cloudy, stiffer onion, and it gets cloudier and cloudier. Everybody gets a cataract if you live long enough. It's just a fact of life, just like wrinkles, that cataract is coming. And so, don't be surprised if you go to the eye doctor and they say you got a little mild baby cataract in there. Most of the time, people don't really require surgical removal of them until you're in your 60s, 70s, maybe 50s for some people. But it's a very routine surgery that we do for tons and tons and tons of people all the time. So when it's time, it's a great surgery and can really help improve the vision. And there's my lens growing like the onion. Next, I want to talk about dry eyes. This is so common, especially, we just finished the winter where everyone is inside and the heaters are on and it's really dry out. And so the surface of the eye, and this is the cornea. So going back to our eye anatomy, it's that clear outer part gets dry and irritated and scratchy. And so a lot of the time it's that like tired, itchy feeling at the end of the day. They feel heavy. They may even water more than usual. And all of that is related to the dryness of the cornea. And so for dry eye, we talk about using artificial tears. They're over the counter at the drugstore. Sometimes warm compresses and kind of scrubbing those eyelids can help. Taking off makeup is really important at the end of the day, because that makeup can clog up some of the tear glands and also cause inflammation, which can make dry eye worse. A lot of the time, dry eye can also be related to screen time. So we're all like on our devices all the time, and we're on our phones and computers. And when you're focused really hard on things like that, you don't blink as much. And so then your eye will get more dry. And so that's where the eye drops can help. And then the 20-20-20 rule. So every 20 minutes, look at something 20 feet away for 20 seconds. And that helps to sort of give your eye a rest, give it a break. It lets you blink and really kind of re-lubricate the surface of the cornea. Glaucoma. So this is very common, especially in our Black and brown patients, and it tends to run in families. And what happens is that the pressure is too high in the eye and causes nerve damage. And so over here, these are pictures of the optic nerve in the back. And for instance, this one, if you look at this inner circle, it looks like maybe about half the size of this whole nerve, kind of like if this is a donut. You want a fat donut with a small donut hole. That's about a third of the size of the whole thing is normal. In this one, this is a really skinny, wide donut. So that donut hole is much bigger, maybe 75%. And then this one is even worse. Like that donut is so skinny. And so these are all the changes that happen in the nerve from the high pressures from the glaucoma, excuse me. And there are different kinds of glaucoma. The most common kind, though, is the primary open angle glaucoma. And people are usually on eye drops once or twice a day for that. There are also laser treatments that we can do for that, and even surgery if those things don't work enough to bring the pressure down to a acceptable range. In glaucoma, typically the vision changes or the side vision first. And so a lot of people don't notice those changes until they're really, really severe. And so this is one reason why it's important to get checked, especially if you know someone in your family has had glaucoma or other eye problems. Macular degeneration is very common, usually in older white patients. The whole name is age-related macular degeneration, and it also tends to run in families. And it's kind of like this accelerated wear and tear on the retina where part of the retina doesn't work as well. And so you get these little white spots, you can see them here, called drusen throughout the macula. And the macula itself is just a part of the retina. It's kind of like, you know, an elbow or a big toe. It's an area. And so in that macular area of the retina, you get these little drusen, and over time it can progress and cause central vision changes, like you can see in this picture down here. And so the dry kind is slow wear and tear changes that can accumulate over time and end up with those central vision changes. And with the wet is usually when all of a sudden straight lines look crooked or wavy. And that means that these abnormal blood vessels have grown under the retina and started to leak or bleed. And so for the dry kind, there's not a lot that we do. It's usually just monitoring it, regular exams, not smoking. You can take these eye vitamins, but the eye vitamins are really just for the dry kind of macular degeneration. Like everybody doesn't need to be on them, only if you have a certain type of the dry macular degeneration. If you turn to the wet kind, then we can talk about doing injections in the eye, which I'll talk a little bit about more later when we get to our diabetes. So looking back a little bit more closely at their eye anatomy, so the cornea, the front part of the eye, the lens, kind of like the lens of the camera, and then the retina is that film in the back. And when we take pictures of it in clinic, we're seeing it like this, where this is that macula area that we're talking about. And then the center vision is that darker spot right in the middle. And so how does diabetes affect the eye? So diabetic retinopathy is what we call it because the retina is affected, and it is very common. It's the most common type of diabetic eye disease is diabetic retinopathy, and it's a leading cause of blindness and disability in American adults. And it's asymptomatic, so there's no symptoms. You don't know if you have it or not until things are really bad. And so this is a comparison of a normal retina, similar to that other picture that I showed. And then this patient has a lot of diabetic retinopathy here. So the retinopathy is these, we call them hemorrhages, but it's not like your eyeballs squirting blood. It's more like little bruises in the retina. And so there can be different types of hemorrhages, and how many you have, that helps us determine how to grade it. So the grading scale is mild, moderate, severe, and then what we call proliferative diabetic retinopathy. And that's the worst phase. And that's when abnormal blood vessels are growing on the retina. So just to go back, so see here, you have all these little bruises. We would call these all hemorrhages. And this person has severe diabetic retinopathy. And then this picture here, you can see all these little lacy, really fine, really squiggly looking blood vessels. This person has proliferative diabetic retinopathy. And so those abnormal blood vessels are growing. They can leak and bleed into the back of the eye, called a vitreous hemorrhage. They can pull on the retina, called a retinal detachment. And at its worst, they can grow into the front part of the eye, cause clogging up of the drainage part of the eye, and make the pressure really, really high and cause a type of glaucoma that very commonly causes permanent vision loss. Another thing that we look for with patients with diabetes is macular edema, which is swelling right in that center part of the vision. And if you have that, then your vision will kind of be like this picture where maybe there's some areas that are kind of splotchy or blurry, but it's not like with the macular degeneration where there's this very discrete center blind spot area there. And so the treatment for this would be injections of medicine that go in the eye. And the injections sound completely insane. It sounds crazy to get a needle in your eye, but there's lots of numbing involved. We don't let you see the needle. And I joke around and tell patients I'm really sneaky with it. And so I just sneak that injection in there. The injections are about once a month until the swelling and those diabetic changes are better. With the proliferative diabetic retinopathy, we can do a laser, and the laser is called pan-retinal laser photocoagulation, and it's a series of laser spots that go into the back of the eye to prevent those abnormal blood vessels from growing and to make them regress. And then at its worst, we can do surgery called a vitrectomy surgery, where I go and take the jelly out of the back part of the eye, fix the retina, put it back where it needs to go, and then put in a bunch of laser during the surgery. So when and how to get screened, and this is a really important topic for everyone, because if you're over 60, you should have a dilated eye exam every 1 to 2 years. If you are Black and over age 40, or if you have a family history of somebody with glaucoma or any other eye problem, then you should get checked sooner than that. And you should be having yearly eye exams. For type 1 diabetics, the guidelines are within 5 years of diagnosis. Because usually with type 1, it's, typically it's in younger patients, children, and we figure it out pretty quickly. Like when the diabetes starts, they have symptoms and get checked and are diagnosed pretty early. For patients with type 2 diabetes, the diagnosis can come a lot later. Like some of you may have, maybe you felt a little bit funny, or you noticed, little symptoms, but you didn't really think much of it. And a lot of people have diabetes, type 2 diabetes, for a long time before the actual diagnosis is made. And so then there's that time period where the retinopathy and those eye changes could be happening. And so the guideline for that is to get screened at the time of diagnosis. So as soon as you get your diagnosis of type 2 diabetes, you should make that eye appointment. Now, who can do the screenings? Optometrists or ophthalmologists. We are the eye care providers. And I made this little graphic just showing the difference between ophthalmologists and optometrists. And optometrists, they go to optometry school after college, versus ophthalmologists, we go to medical school after college and then do a 4-year residency after that, and then potential other 1 to 2 years of a fellowship to specialize in something like vitreoretinal surgery. And so there's just a lot of different hours of training, and we do a lot of the same things, but ophthalmologists, we do a little bit more. So optometrists do contact lenses, glasses, basic eye exams, basic checks, some basic medication management. But ophthalmologists, we're medical doctors. We've been to medical school, and we do surgery and lasers and other types of more invasive treatments. For most people, for basic, no big deal, just getting my checkup, optometry is fine. For patients who may have a high risk of having eye disease, whether because of something like diabetes or family history of other eye problems, or you may need some sort of treatment or surgery, then ophthalmology is a better choice because we have that additional training. So what to expect when you go to the eye doctor? So we'll see you, the front desk will get you checked in, and typically we will do a complete dilated exam, especially if we're looking for diabetes. So we'll check the vision with one of the letter charts like we have pictured here. We'll check the intraocular pressure, and this is everyone's favorite, the puff of air. We have a lot of other ways now to test other than the puff of air, but none of them hurt. But everybody remembers the puff of air test. And that's to check the pressure inside the eye, and that's part of the screening test for glaucoma. Then we'll check the pupils to make sure that they move correctly and together. And then we'll look at the front of the eye with this machine called the slit lamp, which is basically like an up and down microscope. And then we'll check the back of the eye, the retina, and the nerve in the back using the slit lamp and or this like hat with a light on it. Kind of looks like we're going spelunking or something, and a special lens to look at the back of the eye and check the retina and make sure it's doing okay. Sometimes we'll do scans or photos of the back of the eye to either document, or the scans can help us quantify like the amount of swelling that may be there, or to look at other problems in the eye or during your eye exam. So just to get back to the macular, to the diabetes complications and treatments. So with the macular edema, it's that swelling in the center vision. And so this is a picture. So let's say this is a patient who came in, noticed some blurry vision in the eye, and I take a peek at them with my slit lamp, that microscope, and my special lenses, and I'm looking in and I can see all of this kind of yellow white stuff. And that is a sign that there's swelling there, and that's exudates or like lipid that came out from those leaky blood vessels that are causing the swelling. The leaky blood vessels are from the diabetes. So the diabetes causes leaky blood vessels, and then they leak the fluid into the retina, which causes swelling. So it's kind of like if you take a water hose and poke a bunch of little holes in it, and now there's leaking into the retina from those leaky blood vessels, which are like the water hoses. And so this is a scan of the retina, and it's supposed to look kind of like this side over here where all the layers are squished together and close and like lines you can see very well. And then this is the scan through where the area is swollen. And so you can see all these big swollen spaces. And this is a little bit of fluid underneath the retina. So you can see how much thicker it is over here than it is over here. And so this is one of the things that I'm looking at when I'm seeing my patients, and I track those changes to make sure the treatment is effective. And on the scan, it actually gives me a number, a reference of how tall this is. So I can measure and say, okay, is that little mountain going down or is it going up? Do I need to switch treatments? And more. And so we talked a little bit about proliferative diabetic retinopathy earlier. So the most severe form of diabetic retinopathy, and this is another picture here. So that's a similar picture of the back of the eye, but you can see all those abnormal blood vessels that are not supposed to be there. And this patient has some of that bleeding, that vitreous hemorrhage into the jelly in the back of the eye. And so we talked about the bleeding. It can cause the high pressures, or we call it neovascular glaucoma, or the retinal damage, which is the tractional retinal detachment. So treatment, number 1, 2, 3 treatments is control the diabetes. So that's so important, is to get the diabetes under control and really work on getting that A1C or hemoglobin A1C number down. And the studies have shown around 7 is usually a good range that keeps the eye disease in check. But it may vary a little bit per person. And so, you're already working with your primary care or your endocrinologist to work on getting those sugars down, but it is so important for the retinopathy that you do that. And the damage that you get, the diabetic retinopathy, this is like a cumulative type of thing from having diabetes usually for years. And so because you had a cupcake last week doesn't mean you're going to get macular edema or swelling in the retina this week. Or, you had a cold, and, those infections can make the sugars go up. That's not going to cause like a 1-to-1 effect on the retina and the diabetic changes. But overall, we want that nice, stable, low blood sugars instead of the up and down type of changes, because that is more likely to lead you to seeing me and needing treatment. So I mentioned the treatment, the injections, the laser, and then the vitrectomy surgery. And so this cartoon image here is showing kind of what it looks like when we do an injection. So we use this little teeny tiny needle that goes through the wall of the eye near where the colored part of the eye is. And then the medicine goes into the jelly in the back, and it kind of dissolves and works on the retina from there. But like I said, lots of numbing. It doesn't hurt. You don't see the needle. As a retina specialist, this is kind of what I do all the time. Bread and butter. Right before this call, I did a couple patients. And then the other picture here is a picture of the panretinal laser photocoagulation that I was telling you about that we do for the proliferative diabetes changes. So all these little laser spots were put in with a laser machine by hand. And we kind of zap the retina to make sure that those little abnormal blood vessels stop growing and that the blood vessels go away. And then if none of that works and we're still having trouble, then we talk about doing the surgery, like I mentioned. That's an outpatient surgery. So you come in the morning, you go home on the same day. Usually we'll either numb up your eye or in some cases put you all the way to sleep and take out the jelly in the back of the eye so that we have access to the retina, and then fix whatever needs to be fixed in the retina and finish things up. Then you go home with the patch that day and usually come back the following day to get checked and to get instructions. So in recapping, everything that we went over, diabetic retinopathy is usually painless. It can be severe and it can require treatment. So the most important treatment is prevention. So really work on getting those sugars down, control that diabetes, and then get those annual screenings. Annual screenings annually as a minimum is a must. Have to have those screenings because it's painless. You may have no symptoms at all and have really, really bad diabetic retinopathy happening in there. So really, really, really important. And then just a quick thank you. Thank you all of you for your participation and listening. And thanks to our corporate sponsor, Regeneron. I have some social media accounts if you're into social media where I post some things eye related. And at this point, we can open up for questions. I'm happy to take any questions. I'm sure there's some out there.
Absolutely. And thank you, Dr. Randolph, for your excellent presentation. And we have a few minutes and I have a few questions that have come in for our viewers out there. If you have questions, please put them in the Q&A and we'll get them answered. Our first question is from Susan in Chicago, and she says, I have lived with type 2 diabetes for 15 years and my vision is decreasing. I have blurry vision and not sure if it's related to my blood sugar or something else. Can I prevent further vision loss?
Yes, I mean, Susan, you need to get checked. You need to go in and see someone, have a nice, thorough, dilated exam, and really get evaluated to make sure of what's going on. It could be something as simple as needing a new glasses prescription, or maybe the cataracts have gotten a little bit worse, and so they're affecting the glasses prescription. Or it could be something more severe like diabetic retinopathy. And so really, really important to go in and get a check.
Very good. And we have a question that came in from, she said, I am a type 1 diabetic who recently had cataract surgery. So
Awesome.
can you comment on that?
Sure. I don't know if there was something more specific you had a question about, but everybody gets cataracts. Like I mentioned, they're kind of like wrinkles. They're coming for us all. And with the cataracts, having diabetes can make the cataracts happen a little bit faster. In a lot of our treatments can also make the cataracts happen faster. So as a diabetic, you do have a risk of having cataracts maybe a little bit earlier than some of your friends. But in terms of risks in removing the cataracts and the cataract surgery, it's usually not increased unless there's other factors.
She just put another quick post. She says, now I have double vision.
No. Well, you need to get checked. There are a lot of different things that could cause double vision after cataract surgery. If you have diabetic retinopathy, sometimes cataract surgery can make a little bit of that macular edema or swelling pop up and make it a little bit worse. And you can also have swelling just from cataract surgery itself. So in terms of the retina, that could be part of it. Sometimes people notice double vision more after if there's only one eye done and then the other eye's not done yet. So there are a lot of things. It's hard to pinpoint exactly why, but you should definitely get checked.
Yeah, and I love the message to get checked. And I think that's the call to action, how important that annual screening exam is. And we can't say enough about it. So thank you for reiterating that. I always would tell my patients, your vision is like your most precious resource and we need to take care of that.
And like I said, a lot of the problems that go on are so asymptomatic and you don't realize it. You don't know there's a problem until you get checked.
Yeah, absolutely. We have a question that came in from a Cornelia that I have type 1 diabetes for 58 years. What is the prognosis after recent laser for retinal bleed?
So I'm going to make some assumptions because I haven't looked at your eyes. And so it sounds like you probably had proliferative diabetic retinopathy, and they did most likely the pan-retinal laser photocoagulation because those abnormal blood vessels were growing and they were leaking in there. And so the prognosis is still very good. You may be having some blurry vision because you're trying to look through the blood that's in there. It's like trying to look through a glass of Kool-Aid instead of clear water. And so it's harder to see with the blood floating around in there, and you may have floaters and things like that. The important thing is to treat the diabetes and to treat that retinopathy with the laser. The blood itself will go away and eventually will clear. Most of the time clears by itself, but sometimes I'll take patients to surgery and do a vitrectomy and clear the blood out, mechanically by hand with surgery. But in general, we got to treat the cause of the bleeding, which is the diabetic retinopathy. And so that's the laser treatment that you had.
Very good. Okay, and then we have a question. She asks, what about eye exercises?
Eye exercises don't have a lot of scientific proof for children with certain eye problems. Sure, they can work, but for adults, usually they don't really do a lot.
Yep. And this question is from Joanne. My doctor says I need to start treatments. I have diabetic retinopathy, and the treatment is an injection in my eye. I'm very nervous. Will this help prevent further vision loss? Is there something else I should be doing?
No, you were doing all the right things. You went in, you got screened, you had your exam, you found the problem, and now your doctor wants to treat it. So that's like the best kind of sequence of events that we can have for a patient. I know the injections sound really scary, and they are not so bad. Once you have one, you'll be like, oh, that was nothing. I was really nervous, and it turned out way better than I thought. But you know, we do this all the time for us. This is routine standard operating procedures. I know for you it's completely wild, but for us as retina specialists, we do it all the time. You know, yesterday I saw probably 30 patients that I did injections on. So it's very, very routine. We have lots of ways to make it as comfortable as possible because, you know, if I have to do this for you all the time, I want you to be comfortable. You know, I don't want you to be, you know, uncomfortable and cause pain. So we have a lot of ways to treat it and get you really comfortable with numbing, and using lubricant drops like artificial tears afterwards can help if there's a little scratchiness. But I totally I hear you. It is definitely scary, but it sounds like it's what you need. And the point of that is to keep your vision good and maybe even improve it a little bit if some of that swelling is in the center vision already.
Perfect. And another question she said, how do you decide injections versus laser for retinopathy?
It depends. That's a great question. All of these are fantastic questions. Thank you guys so much. It depends a lot on the patient. So clinically, if I'm looking at it and I get worried that you may need surgery soon, or if it's someone who's really sick and maybe, you know, has been in the hospital a lot, I may lean more towards laser, because generally speaking, once we get enough laser in there, then I can push the appointments out and watch a little bit more. The injections work quickly, they work fast, and they are good, but they wear off after a month. And that's why it's a series of injections. And so, you know, I have some patients, and let's say I know they're going to have a hip replacement and they may not be able to come for a while. Then doing the laser may help prevent things from getting worse instead of having a gap in treatment with the injections. And so that if patients have the macular edema, the swelling in the back of the eye, the injections are the first line treatment for that, versus if it's the proliferative diabetic retinopathy, then you can do either injection or laser. So if it's somebody that has the PDR, proliferative diabetes, and macular edema, then I'm more likely to do injections, because then I'm killing two birds with one stone.
Yeah, and that's where you have those great conversations with your healthcare provider and your ophthalmologist, that shared decision on what treatment would be best for you.
Exactly.
Great questions. We have a final question from Melissa in Ohio, and she says, I have glaucoma and use drops. The drops are very expensive and they burn my eyes. Is there any cure for this? And do I need to take them for life?
So generally speaking, glaucoma is a lifelong disease, and the point of the drops and other interventions is to slow down the progression so that you don't lose vision from it. Now, in terms of glaucoma, drops are one type of treatment. There are also laser treatments, and there are also surgical treatments. And so this is another thing that's really important to have a conversation with your doctor about, because it may be that the drops aren't working for you because they burn, or, you know, because they're irritating you, or, you know, some people even it's just hard to take them. It's hard to remember. It's hard to get them in. And all of those may be reasons why a laser treatment or a surgery may be a better choice to keep your vision longer. You know, we'd rather have you changing things up and keeping your vision than to kind of suffer quietly and not let us know and then have problems later. So really important to just have those conversations, keep a list on your phone app or in your purse of questions you randomly think about and bring them to your appointment. I love it when patients do that because I really want to take the time to make sure that we're on the same page about what's happening, how to best proceed, and what what you need and what's going to be best for you, because everybody's a little bit different. And we have the data saying this treatment works, but this treatment may not work for you because of your life or whatever. So really important, get in, get screened, have those conversations, and encourage your family members also to get screened and to come in and get checked.
Very good. Great tips. Well, we're just about out of time, and I just want to thank you all for your questions, and I want to thank for sure Dr. Randolph for the wonderful presentation. So at Diabetes Sisters, we know that diabetes and eye disease is a topic of interest. So to continue this discussion on eye disease, Regeneron is also sponsoring our May newsletter, which is a series of 6 comprehensive articles on diabetes and eye disease. If you're not subscribed, visit our website. Regeneron is also sponsoring our next expert series on June 13th at 12 noon. The theme will be Nutrition for Healthy Eyes. Janice McLeod, a very well-known registered dietitian, will be presenting up-to-date information on how nutrition plays a huge role in eye disease. And for those of you who would like more opportunity to learn and network with other women, we who have been dealing with this complication of eye disease, join our interactive workshop. It will be led by 2 amazing women, Reva Greenberg, who is a woman living with diabetes, a health coach and an inspirational speaker, and Amy Jordan, a woman who has lived with diabetes and eye disease, who is legally blind and has triumphed in her life living with eye disease. This event will be on May 29th at either 12 noon Eastern or 7 p.m. Eastern time. And please note, you need to be a member of the Diabetes Sisters community to sign up. So go to our website, hit become a member, and then go to our events calendar and find the event and join and sign up for the event. Remember, it's free of charge, and it's a time to gain knowledge and tips from our speakers and other women dealing with eye disease. Again, a big thank you to Dr. Randolph and to Regeneron, our sponsor. The program was recorded today and will be made available on demand on our website in the upcoming days. So thank you for joining. We hope to see you on May 29th. So everyone have a wonderful day. Bye-bye.